Hi, everyone. Welcome to today's Grand Rounds. This is Julie Salvador, Associate Professor in the Department of Psychiatry and Behavioral Sciences. And I'm very glad and proud to introduce our two speakers today, Phil Feudy from the Mountain Center and Dr. Rich Gadomski, who is part of our department. So I'll give a few formal introductions. Richard Gadomski is from New York, where he studied political science and economics as an undergraduate at Colgate University. He subsequently completed a pre-medical post-baccalaureate program at Harvard, focusing on neurobiology, and attended the University of Maryland School of Medicine. During his preventive medicine residency at the University of New Mexico, Dr. Gadomski trained extensively in addiction medicine, clinically, the opioid epidemic from a public health perspective, and simultaneously earned a Master's of Science in Clinical Research. He was then appointed to faculty at the University of New Mexico School of Medicine in the Addiction Division within the Department of Psychiatry and Behavioral Sciences. He splits his time between clinical care and teaching at UNM's Addictions and Substance Abuse Program and a low barrier buprenorphine program, which they are going to discuss today, which he initiated in conjunction with an existing harm reduction center in Rio Arriba County, which has one of the highest fatal overdose rates in the country. Dr. Gadomski also has experience as project director in his role for a HRSA-funded opioid prevention, treatment, and recovery grant in collaboration with a rural network of federally qualified health centers in northeastern New Mexico, as well as the New Mexico Department of Health in a CDC-funded opioid overdose prevention project working with indigenous groups. Philip Feudy provided underground syringe and naloxone distribution in rural New Mexico in the early 1990s, was a harm reduction volunteer for the AIDS Resource Center of Wisconsin, a harm reduction outreach specialist for Albuquerque Healthcare for the Homeless, and the harm reduction program manager for the New Mexico Department of Health from 2002 to 2006. He also has been involved with education and harm reduction efforts around methamphetamine, safe access to medical marijuana, and examining innovative treatments for substance use disorder. He's currently the harm reduction program director for the Mountain Center in northern Santa Fe and Rio Arriba counties in northern New Mexico, and as a consultant, administrator, and trainer for several federal overdose and opioid use disorder grants in New Mexico, and a new grant to examine and develop resources targeting polysubstance use in New Mexico. So for a slightly less formal, I will just say one more word. I'm really excited to introduce these two speakers in this program. This program is funded by the Behavioral Health Services Division under the State Opioid Response Project or Initiative that I am the project director for. And this was an innovative idea in collaboration with the Mountain Center team, Dr. Snehal Bhatt and Dr. Rich Gadomski. And they've really gone above and beyond even what we originally thought this would turn into. So it started with a little bit of the Mountain Center working with buprenorphine. And then we started at this program, this low barrier program, and Dr. Gadomski has taken the bull by the horns and has really expanded it now into a full service primary care and behavioral health center in collaboration with the Mountain Center. So without further ado, Dr. Gadomski and Phil Feudy, please begin your presentation. Share your slides. Thank you.
Thanks very much, Julie. I really appreciate it. So I'm just going to go ahead and share my screen, and Phil is going to do the initial part of the presentation. And Phil, just let me know as you need me to advance your slides. So just real quick, we have nothing to disclose, no conflicts of interest.
Oh, okay. Well, I was going to do that, but there we go. Yep, nothing to disclose. Thank you for the introduction, Julie, and the opportunity to present in this context the other day. My name is Philip Feudy, the Harm Reduction Program Director for the Mountain Center, and I'm going to try to explain the Mountain Center and our harm reduction program in 5 minutes so we can get into the real meat of this. I've been with the Mountain Center 8 years now, and really owe a debt of gratitude both to the organization and to the communities in the north here that it's just been an amazing opportunity to do work, and the relationship with both the folks that we serve up here, but the larger community and other providers up here to given us the ground to do this work. So go ahead, Rich. For those of you who may not be totally familiar with the Mountain Center, we were founded in 1979 to do outward bound type work with folks, experiential education and adventure therapy. But our target was a little bit different, and we wanted to focus on working with at-risk individuals in the community, so youth and adults. We were first got involved in HIV prevention services in 1996 with the development of our Adventure Out programming, which ended up becoming a CDC recognized intervention at the time, and it was combining HIV prevention messaging and skills in the context of doing resiliency building activities out in the climbing and out in the wilderness. And later on, we became the home for what used to be called the New Mexico Gay Straight Alliance, recently rebranded as the New Mexico Genders and Sexuality Alliance, and that runs, sets up and does a lot of the anti-bullying programs in the clubs and schools all across the state. Began providing harm reduction services in northern Santa Fe and Rio Arriba County in 2005. At my behest, actually, I was in charge of I was the harm reduction manager for the state at the time. And because of the amazing work that the Mountain Center had done with Adventure Out, thought they would be a good program to take on the services in this part of the state. So that got underway in 2005, and we moved into providing office-based services in 2016. Beginning in 2014 was the first year that we surpassed distributing 1 million syringes, and it's gone up every year since then. And we cover about 6,000 square miles in our mobile outreach. So all of Rio Arriba County, northern Santa Fe County, and southern Taos counties. And that makes us, one of the neck and neck is one of the largest providers in the state, but also one of the largest in the country. Okay, next. So FY21 was a difficult year, but we still did a lot of really good work as an organization. Our therapeutic adventure programs did take the biggest hit. We did manage to provide programs, mostly as in youth day camps and things, while people were at home and the kids were not in school. But most of our adult programs got postponed as a result. Our work with the treatment centers and correction facilities and things, because nobody was going in and out of those places. On the other hand, Genders and Sexuality Alliance really knocked it out of the park. A good part of their work and programming is done online anyways. And our counseling services really accelerated during this time too. For some reason, both with the larger adolescent and family counseling that the Mountain Center does, but our counseling services through the drug court program up here in Rio Arriba County, the folks that we're working with really took to the online format. So next. Again, for those of you who may not be familiar with the harm reduction programming in New Mexico, or just came into it and it's always been here. New Mexico became the second of only 2 states, Hawaii being the first, that not only legalized doing needle exchange in the state, but actually mandated in legislation that the Department of Health would provide these services targeting folks that were using IV drugs in the state. And that part of the component of that would be, attaching other interventions and things to it, and that we would be collecting data and, providing vaccines and doing all the rest of that in the context. So the first programs were launched in 1998. So we're up 23 years. We'll be having 24 years here pretty soon. And that basically provides our law provides an immunity or criminal liability for both providers and participants for syringes in the state paraphernalia statute. We became the first state in 2001 to actually get legislation down that allowed us to put naloxone directly to folks that could use it. It was pretty groundbreaking at the time, and it's been followed by a few other cool things, including the in 2016 legislation that allowed us to do by standing order, allowed people with non-prescribing abilities, such as myself, working under the direction of a physician, to distribute naloxone ourselves. And since the day that Governor Martinez signed that piece of legislation, we've had Narcan on all shifts at all the time. It's been really a blessing to do that. Next. So we were another program with the Mountain Center that really excelled the past year. We have over 2,000 unique individuals. The 1,802 listed up there were solely folks that we did syringe exchange with. In those encounters, we do a lot of other safe use supplies that we don't track necessarily, and food and hygiene and other items that we don't track by encounter. So our syringe services were almost just under 2,000 people. We did 2.2 million syringes last year. Our collection rate, the 86.7, one of the better ones in the state. It's a little low for us. We had several years running where we were over 100% in that. And part of that has been that we've really taken up a big presence in the community, working with law enforcement and landowners, property owners, the pueblos, and home healthcare patients, and other folks who come into contact with sheriffs over the course of their lives or work. And so we participate in that. In fact, the local police department just put us on dispatch. So if somebody calls and there's something going on where there's syringes involved, they just call us and we go pick them up. So it's been very successful. Our overdose prevention, naloxone distribution, 466 successful reversals. That number is also a little bit low for us this year. I'm not sure why, but statewide there was a drop in requests for naloxone in January and February. And then in March, the second wave of fentanyl showed up in the state in the form of the counterfeit pills that are causing so much havoc now. And so we're, in spite of the fact that the number of encounters or the number of individuals was a little low, we also had our busiest months ever in terms of overdose prevention. So as a subcomponent of that, we work with the Prescription Drug Overdose Project, for Santa Fe and Rio Arriba counties, where we go out and provide naloxone to other community partners who are also interacting with the same communities that we work with. Here's the one for today. This is, we've been experimenting with Suboxone with some different providers and things for a couple of years, but this year it really took on a formal aspect in our collaboration with BHSD at UNM and having Dr. Rich join us. So what we're calling our recovery support services, which is several different things, including case management and counseling. We saw a total of 120 unique people 795 times. And that is people, there's a few of those that are connected to the drug court. But most of them are just straight referrals from people who are accessing syringe services here. Our hepatitis and HIV counseling and testing, and now treatment. The specific services for that were a little low this year, but again, it was hard to, there was a part of FY21 where we weren't allowing people into the building. And we're doing most services remotely, and we do a lot of outreach testing and stuff. And, again, most of those were on hold, but we still managed to provide services to 57 people in that. Weirdly enough, we were able to keep our auricular acupuncture stuff going. Again, that was pretty small, but we were able to go internally through other Mountain Center programs, and we're able to get some of that. And again, our nutritional support and hygiene, over 7,000 people that we, were able to provide that to. When COVID started in the beginning of the previous year, we had deliverables and things that suddenly we weren't going to be able to meet through some of our other funders. And I was able to convert most of those deliverables into food and hygiene and some other tangible items that we were able to then purchase and give away. So being able to provide food has also given us a lot of inroads in the community, way beyond just folks who are injecting substances. So next. And just a little overview of where we are currently. Got a budget this FY22 at 905,000. It's a combination of stuff, sources, primarily New Mexico Department of Health Hepatitis and Harm Reduction Program. Again, the way that things are structured in New Mexico, we have a fairly, it would seem modest, the funding that we're getting from the Department of Health specifically to those services, but because the Department of Health also provides the syringes, naloxone, disposal, and other supplies, that means that the money that they do provide to us is intended to support us to develop services and in a way that is unique or addresses the unique needs of the community that we operate in. And so in that sense, we end up being one of the best funded programs in the country, as do other contracted providers in New Mexico. We're working with through BHSD and OSAP, working with multiple federal grant projects. In the year 2 of a 3-year project with what was formerly through Christus and Quorum, but it's the Community Health Funder Alliance. That has been a big part of getting our MOUD program off the ground initially. We have a private funder that would like to remain anonymous, but they have been with us almost since the beginning and renew the support that they give to us each year. Rio Arriba Health and Human Services, and of course UNM in multiple ways, not only like through the project where we have Rich and Julie and the SOR funding, but we've been working very closely with Dr. Page, Kim Page's team for a number of years. Completed one study on hepatitis C amongst young people 18 to 30 here, and got some really interesting information out of that. We've worked on a methamphetamine study prior to COVID, and we just got more funding to do an expanded version of looking at methamphetamine use in rural New Mexico. That's going to be starting pretty soon. So that's where we're at, and I will pass this over to Rich.
Thanks very much, Philip. That was excellent. And I just want to say it's been really an honor and a privilege to be working with you, and your dedication and experience and passion is really an inspiration. So I'm just going to zoom back out to sort of a 30,000 foot context for what we're doing. And that really involves the fact that the United States saw over 93,000 fatal drug overdoses in the year ending 2020, certainly exacerbated by the COVID epidemic. But I think it's important to keep that in perspective because it's higher than at any point since the opioid epidemic began, higher than in the initial years of the HIV epidemic before antiretrovirals were available, and very arguable that a lot of this is being driven by stigma, just as it was during the HIV epidemic and the sluggish response that we saw there. And at least in 2019, opioid overdoses were the leading cause of death under the age of 50, resulting in tremendous years of potential life lost. Rio Arriba County specifically ranked number 20 in 2019 for fatal overdoses nationally, one of the few counties in the West to do so. And this is really part of why we decided to localize our efforts in Espanola, where there is a generational opioid epidemic and driven in part at least by high rates of trauma. Many people would argue that opioid use disorder is a symptom of trauma, in fact, and people are self-medicating their PTSD in the first place with opioids. The only other place I've really seen a generational opioid epidemic like this was in West Baltimore, which has one of the highest rates of opioid overdose in the country as well. So in light of all this, there's a growing consensus, if not a very established consensus, at least among addiction medicine and harm reduction folks, that the status quo is absolutely unacceptable in terms of what we're doing to address the opioid epidemic. And so the project that we're working on is geared towards developing a new progressive and aggressive approach to addressing the overdose crisis. And again, the incredible amount of years of potential life lost among these young folks, often under the age of 50, who are passing away. And the project is really centered on removing as many barriers to buprenorphine access as possible. And I will get in a little bit into why buprenorphine is so important for this process. This is a slide that I borrowed from my good friend, Dr. Bott. And the quote from Walter Ling is, "Detoxification from heroin is good for many things, but staying off of heroin is not one of them." And this is where medications for opioid use disorder, including naltrexone, methadone, and buprenorphine, come into play. This was a relatively small RCT that was done in 2003, but you can see on the top line that those who were randomized to buprenorphine had a significant higher level of retention and treatment over the course of a year. That arm also saw 0 deaths, whereas those who were detoxed rapidly from opioids, which by the way is a very unpleasant, if not cruel experience, saw tremendous dropout from treatment and also 4 deaths. And while this is small, it tends to correspond and extrapolated well with real life experience that I've seen. So low barrier buprenorphine as a treatment modality is something that's becoming more popular and more advocated for, but still somewhat in its nascency. We attempt to remove as many barriers as possible to buprenorphine access in our project in Espanola. And it's also synonymous with low threshold modalities, but I don't like that term as much because it really only suggests that, and it should always be the case that only a diagnosis of opioid use disorder is necessary to initiate buprenorphine. As I mentioned, buprenorphine and other medications for opioid use disorder are critical first-line treatments and are life-saving medications. But unfortunately, and very problematically, the availability for this medication is significantly limited. Where in reality, I think that this medication should be available in every mental health and primary care outpatient setting. From a harm reduction and a public health perspective, I think it's fair to say that because buprenorphine is such a safe and life-saving medication, by the way, as a partial agonist, buprenorphine has a respiratory depression ceiling. And as long as you're not mixing that medication with benzos, alcohol, it's very difficult to overdose on buprenorphine, unlike other full mu opioid agonists, for example, methadone, oxycodone, heroin, fentanyl, et cetera. And from sort of a humanistic perspective, which I think is really often overlooked, buprenorphine empowers people to break the cycle of use and withdrawal so that they can focus on other priorities in their lives. For example, housing, repairing relationships, and employment. And to borrow a quote from my esteemed colleague, Leslie Hayes, who's done incredible work for El Centro up in Espanola, and as someone who worked in primary care, people don't often thank you for getting their systolic blood pressure below 140, but I've routinely had people thank me for really turning their lives around and stabilizing their lives in a really impactful and positive way. And so I guess what I'm saying is that from a provider perspective, providing buprenorphine treatment is a really satisfying and powerful, meaningful experience. So Phil did a great job discussing harm reduction, but for some of the folks that are not totally familiar about the basics, and I'm just going to read this because it's more succinct than what I could do off the cuff, but harm reduction is about offering options that can help people. It includes stable housing, access to life-saving drugs like naloxone that reverse an opioid overdose, drug checking, for example, fentanyl strips that can detect adulteration in the drug supply, and syringe exchange services, and connection to many other social resources. And that's from the Drug Policy Alliance. So we are co-localized, as Phil mentioned, with the Mountain Center, which is a harm reduction site and a syringe services provider. And critically, this represents a safe space for persons with opioid use disorder. The harm reduction philosophy that is employed inherently involves meeting people who use drugs where they are in a non-judgmental, low-pressure approach. And this really creates a safe space and sense of community for a population that is historically difficult to engage in terms of medical and psychiatric treatment. So critical to our approach from the inception of this project was to bring buprenorphine to an existing syringe services provider and harm reduction site, i.e. the Mountain Center, thereby targeting a treatment population, again, that's hard to engage but where they already are congregating and have a sense of community and feel safe due to the great work that Phil and his team have been doing to build trust and respect and rapport with this community and this population. So all of that is sort of leading up to this concept and this treatment modality that we have now, which I think is kind of unique. And it's really providing full spectrum care tailored to meeting the needs of people who inject drugs and people with opioid use disorder far beyond buprenorphine in and of itself, and really represents holistic biopsychosocial treatment for this high risk and vulnerable population. And we feel that this is really a progressive and aggressive approach to the opioid overdose crisis and all the morbidity that comes with that. So in terms of services that we're offering, we're doing broad psychiatric prescribing, including treating on-site schizophrenia, bipolar, severe PTSD in combination with buprenorphine. And we're now actually offering Sublicate, which is a real game changer for people who have Sublicate, by the way, is long-acting injectable buprenorphine, and a game changer again for people who have difficulty adhering to the daily sublingual medication for whatever reason, people currently experiencing homelessness, transportation issues, etc. Critically, we're also complementing medications with counseling, most importantly, trauma-focused therapy, as well as peer support and case management. And obviously, as mentioned, harm reduction services, which are crucial. I think what's really exciting is that we're now, again, offering targeted medical services that are really pertinent to this population that injects drugs. Hepatitis C treatment with echo support, we've rolled out successfully, and really, I hope to really ramp that up and augment those services and make them more available. The prevalence of hepatitis C is very high in our population, and as many of you may know, it doesn't tend to manifest itself until late stage disease, which is often kind of inexorable at that point. We're also offering PrEP and PEP. PrEP is pre-exposure prophylaxis, which prevents people from contracting HIV, especially good for high risk folks, MSM, sex workers, people who inject drugs, of course, et cetera. And then also post-exposure prophylaxis. Similarly, we're offering HIV antiretroviral initiation and referral as needed, again, with echo support. We're doing primary care light. So, I'm comfortable managing diabetes with metformin and doing blood pressure control. I think we're really proud of the reproductive health access that we're providing and treating STIs, doing antibiotics for cellulitis. A lot of people with chronic injection wounds, which can lead to amputation, sepsis, can become very problematic. So again, in summary, I think we're proud to offer a suite of services that are tailored to this specific population. Some of the challenges we've seen, first and foremost, include stigma. There's a prevailing public narrative in our country and in New Mexico, which suggests that disease is a moral failure and that it's a choice that people make. Whereas in reality, addiction is a brain disease modified or created by neuroplasticity due to exposure to the drug, and it becomes a chronic relapsing disease, not unlike hypertension or diabetes or asthma, and needs to be treated with medicines long-term, such as buprenorphine or methadone, much like insulin or amlodipine or albuterol. And I will say, particularly for this audience, that there, I'm confident in saying that there exists stigma among providers themselves. Again, my colleagues and I are sometimes just confused, and our minds are kind of blown about how buprenorphine is not offered in a more prevalent manner, across the country and across the state. Given the prevalence of opioid use disorder and the morbidity and mortality that's associated with it, I really feel like it's appropriate to be offered in virtually all mental health and primary care settings. Finally, in terms of stigma, there's a lot of internalized stigma among patients themselves, which prevents them from reaching out for help. A second challenge we've seen is patient retention. For other projects that I've looked at similar to ours, 40% is the ballpark that we're seeing at 6 months. And this is due to myriad reasons, including psychosocial instability, again, stigma, and the nature of opioid use disorder and addiction as a chronic relapsing disease, which brings people in and out of treatment sporadically. There's a lack of awareness and education re effective treatment. COVID was a barrier for obvious reasons in the last few months. And I will say finally that pharmacy level barriers are significant in terms of buprenorphine access, which is frustrating because so many efforts have been made to increase the amount of providers that are providing buprenorphine access and writing scripts. And then patients arrive at the pharmacy and they find that they're discriminated against. The pharmacies are not providing or stocking adequate supplies of buprenorphine. They frequently run out, place people on wait lists. And that may be due to ongoing litigation and pressure from the DEA. But the reality of the matter is that every time someone shows up at the pharmacy and is not able to fill a script is an opportunity for them to relapse, overdose, and potentially die. So in terms of future directions and sustainability, we've recently received a second round of funding through BHSD, facilitated by Julie and other folks, which we are very grateful for. We plan to hire additional providers, counselor, case manager, and the whole sort of project within the Mountain Center has been rolled up into what we're calling the recovery support services, as Phil mentioned. And our goal is to become financially sustainable in the next year or so by billing all services to Medicaid. So I wanted to give a special thanks to the Behavioral Health Services Division, particularly Neil Bowen and Tiffany Wynn. The SOR grant and SAMHSA have funded our project. Julie and Snehal really have been instrumental in getting this project up and running and making it successful. And last but not least, Tony Dixon for embracing us and having the vision and the chutzpah to get us going and make us sustainable. So that's all I have. I'd love to open up questions, possibly for Phil first and foremost, if people have them.
I was just curious about who you mainly see and thank you so much for this presentation. It's really helpful to know that this kind of organization exists for New Mexico and for Northern New Mexico. But is it mainly people in Espanola, or are there people who come from all over?
I'll let Phil field that if he wants, or
I think, yeah, I think the majority of the folks that are accessing the recovery support services are pretty centered around Espanola and the neighboring villages. One of the reasons that we're kind of excited about the Sublicate and being able to offer that resources for a couple of reasons. Number one, we've seen, and it just an explosion in people experiencing homelessness in the valley here, and it's unusual compared to other places like even Taos, where a lot of the people who are in that situation are transient. We have a whole expanding population of folks going through homelessness who are actually from here. But you know, it comes with all the same difficulties that people have in that situation anywhere. And you know, you're losing your stuff, it's getting confiscated, people are stealing it, etc. And so we're excited about the Sublicate for that, but then also for the larger county. Rio Arriba County is very, the disparities here are pretty extreme in terms of things like food access and medical services and other things. And there's only a pharmacy in Chama and 4 pharmacies here in Espanola. And so we our outreach sees clients over the entire county, but people don't have access to, you know, to, even if we were doing things via telehealth, it's like they still have to come here or there in order to fill a prescription. So we think the Sublicate is going to be a boon to the folks working that live in the mountains here. So.
Thank you.
Mm-hmm.
Hi, this is Davin Quinn.
Dr. Quinn.
Hi, I just want to say thank you, Dr. Gadomski and Dr. Feudy for this presentation. And I just would love to piggyback on and ask a question of you. You know, you're sort of surprised that not everyone, 100% of practitioners who could qualify to prescribe buprenorphine, why wouldn't they do this? Why would they not get certified or get the waiver? You know, when so many drugs in psychiatry, you know, are debated about whether they even work at all. Here's a drug that works and everyone agrees works and saves lives. I mean, do you have anything that you might say to us to sort of convince us to become 100% buprenorphine certified in our department?
Thank you very much for that question, Dr. Quinn. I think, you know, unfortunately, because buprenorphine is a somewhat newer drug, a lot of people perhaps didn't get exposure to it in their training. And as an opioid, I think sometimes people are intimidated about the safety profile. But as I mentioned, you know, as a partial agonist, buprenorphine has a respiratory depression ceiling and is much safer than full mu opioid agonists. And as a partial agonist, also it tends not to, people tend not to need escalating doses. People don't develop a tolerance to it. And in the Suboxone product, it's a dual product that has naloxone in it, which only becomes activated when it's injected parenterally, and that's significantly prevents misuse and diversion, which I think people are concerned about as well. But for those who want to learn more about it and become more comfortable, I would really encourage people to tune into the MAT Echo that's done weekly that Julie runs, and Snehal Bhatt often gives talks, and in addition to Dr. Larissa Maley. And I think that's a great way for people to become more comfortable with prescribing buprenorphine. And I'm sure Julie would be happy to share that information with everyone.
Well, and I would add one of the La Familia Health Medical Center in Santa Fe a few years ago went about getting, you know, they're a very large operation, and they had quite a few people, physicians assistants, nurse practitioners, or MDs that qualified to do this. And so they set out to get all of them able to do this and be able to then treat folks with through the different departments or different they don't all take like a full caseload of people specifically for this, but it allows them to work in that context with people. And I think Wendy Johnson over there would be someone who could maybe, and Miriam Salazar, who oversees what they call their harm reduction program there, which is the Suboxone and MOUD stuff, would be great resources.
And I'll
Thank
just throw out, Dr. Quinn, another thing that we've come across in the SOAR grants and in my travels in this area. The data waiver that used to be required, there has been a lot of dialogue and publications around just having that 8-hour requirement and 24 hours for the advanced practitioners is itself a barrier, which made it seem like this was a really difficult medication to use and I need a special waiver and I'm going to get audited. And so they've removed that. And at the end of April this year, that's gone. If you're wanting to start with 30 or fewer active patients. And so we're hoping that goes a long way to having people see this as just a normal medication in the toolkit.
Thank you. I mean, you guys are the leaders, the regional leaders and experts, and it's profound to me that you go around teaching everyone how to do this, and our own department is not fully on board with this. So I would love to see our department at 100% buprenorphine certified. Just my 2 cents. Thank you.
And Dr. Quinn, if I can just make a plug for another SAMHSA grant that Dr. Bott and Dr. Salvador have been involved with, which is a PCSS grant that has now fully embedded the data waiver training into the second-year curriculum for all medical students, nurse practitioners, and PA students. And based on the success of which will be sustained now after the grant has ended. But because of the success of that grant, it has now been expanded, and in the next 3 years, it will be embedded for all nurse practitioner concentrations, as well as the adolescent medicine residency program. So one of the things that the data shows, of course, is that if you're exposed to this early in your career and as a student, the likelihood that you'll use it when you get out is much higher. So we're really excited to be able to provide that as well.
I just wanted to express my gratitude out loud to all three of you, to Phil, Rich, and Julie. It's got me motivated, and it's a great reminder. I'm going to go start working on my certification right now. But wanted to say, Phil, when you threw out the number, your first year of 1 million needles just blew my mind, and I only wish you were all here in the auditorium with us so we could have interrupted you with thunderous applause that you deserve. Thanks so much for this work.
Welcome. I was recently speaking with Steve Jones, who used to be with the CDC, retired now, and he was this back when syringe exchange was first becoming a thing, and lots. I think it's probably the most studied disease intervention on the planet, just because of the controversial nature of it. But he said that they had done a study at some point that determined or hypothesized that in order to prevent HIV from spreading within a community of folks that were injecting substances, you needed to do about 1,000 syringes per year per person. And that is actually sort of what we've been able to achieve in this area. And two things we've seen: there's been no increase or even spread of HIV in this community since all of this has happened. You can't really read data that way and say, well, look what we prevented, but that has not happened. Conversely, we actually identified one of the very first people that we treated that came in to see Dr. Rich we ended up identifying as in need of those services. And it's, it's a challenging individual, but we've been able to initiate services with them. So.
I have a question, Phil, for you and possibly Dr. Gadomski as well. But what is your next step if you guys might consider expanding this program to another location? I know you're up, Santa Fe now. What might be a location that you might expand to in the future?
At the beginning of COVID, I got a message from providers up in Taos, people doing behavioral health work, and from the hospital there through our health council, that they needed some assistance with, they were dire need of harm reduction services in the community. And so we actually were able to add Penasco and Taos to our service area in 2020. Late 2019. And those relationships have been developing. I was recently working with the county EMTs, the emergency medicine folks up there, and they wanted to do leave. They wanted and are now doing leave behind naloxone. They told me that up until a few years ago, they never had overdoses that they responded to. And in the past year, it's become a daily thing. It's sort of the number one thing that they're dealing with up there. And so there's the hospital has initiated Suboxone through their emergency department, which is a really cool thing, but they're lacking providers in the community and stuff. And so we've been beginning conversations of teaming up with people to either provide services on site with them or, via telehealth, or possibly trying to replicate what we're doing here in Taos on maybe a smaller scale. So.
Great, thank you. And another, possibility, if there is future funding under the SOAR grants, which there potentially will be, another thought for folks on the grand rounds today is for some consultation from doctors, Bott and Gadomski and Phil Feudy around how to start this up in other locations, because it's certainly a great program. We like to see more of it. Thanks. Any other questions or comments? And if not, you get a little extra time back. All right, I don't hear anything. So thank you so much again, Phil Feudy from the Mountain Center. Appreciate it. And Dr. Gadomski, thank you very much. And Snehal, I don't think he's on here, but Dr. Bott, thanks for the idea that you have put together with the Mountain Center and Dr. Gadomski. Thanks, everybody.
Thank you.
Thank you.
Bye.